Now, this is definitely not my favorite chapter. We will have to deal with complex physiologic issues which help us explain what we see on the echocardiogram in the setting of tamponade and later on also in constriction. We will talk about interventricular dependence, interpericardial pressure, and also intrathoracic pressure. The major physiologic feature of tamponade is that of elevated intracardial pressure and impairment of systemic venous return, which is influenced by the intracardial pressure, but also by the intrathoracic pressure. The elevation in the intracardial pressure is caused by the fluid accumulation. The heart cannot move within the pericardial sac. To truly understand the echocardiographic features of tamponade and tamponade in general, you have to understand that tamponade is not an all-or-nothing phenomenon, but that it is a staged process. In other words, we will have mild forms and full-blown forms which are a medical emergency. Largely, the degree of tamponade is determined by the ratio between intracardiac pressure in the ventricles and intrapericardial pressure determined by the pressure caused by the fluid accumulation. In general, it is a question of how strongly is diastolic filling impaired and how strongly is therefore cardiac output impaired. If cardiac output drops significantly, we have cardiogenic shock, a medical emergency which must be treated urgently. But cardiac output usually only drops significantly if we have rapid fluid accumulation within a short time. Otherwise, the pericardium is able to adapt to the fluid accumulation within the pericardial sac and it can expand. Now, I know this sounds all quite complicated, but it's not that complicated at all. Let's go through the physiology of pericardial tamponade step by step. First, let's look at normal filling. Filling of the right heart occurs mostly during systole via the systemic venous return. This systemic venous return occurs not because there is a pump that pumps the blood into the right heart, but because there is suction. Suction caused by a difference between the intrathoracic pressure and the vessels which lie outside the thorax. And intrathoracic pressure changes during respiration. If we inhale, so during inspiration, this pressure gets more negative, it gets less. Therefore, the gradient increases between the systemic venous return and the right heart, and therefore more blood is sucked into the right heart during inspiration. This is not the case for the pulmonic veins, where flow stays quite constantly throughout respiration, simply because the pulmonic veins are not encased within the pericardial sac. Even with echocardiography, there are a number of ways how to demonstrate that there is an increase into the right heart during inspiration. For example, if we use a pulsed wave Doppler across the tricuspid valve, we can see that flow increases here during inspiration. And if we observe the inferior vena cava during inspiration, we can see that the size of the inferior vena cava decreases. It can even collapse completely. This is indicative of increased flow during inspiration. And here's an MO tracing which shows you just that very nicely. During inspiration, we have a decrease in the size of the inferior vena cava. Now remember, this does not happen for the pulmonic venous return. Therefore, we have more flow into the right heart during inspiration versus the left heart. In any case, the size of the heart increases during filling. Therefore, the heart has to expand. And it expands in all directions because there is no limitation to expansion. And because the pressure in the left ventricle is higher than that in the right ventricle, we have a rounded shape of the interventricular septum. The septum bulges to the right. But what happens if we have fluid accumulation? Then we have an increased intrapericardial pressure which does not allow the heart to expand. This is a problem especially during inspiration. Remember, during inspiration we have more flow into the right heart. Therefore, the right ventricle expands towards the left ventricle and therefore shifts the interventricular septum towards the left, and the septum bulges to the left. Again, just to summarize, the pulmonic venous return is not influenced by the intrathoracic pressure. only the systemic venous return. Especially during inspiration, we have more flow into the right heart versus the left heart. The right ventricle cannot expand laterally, and to accumulate the increase in fluid and pressure, it shifts the septum towards the left. And what happens during expiration? Well, during expiration, the interthoracic pressure rises and causes a concomitant increase in the pulmonary vein pressure, and therefore we have an increased filling from the pulmonic veins. This increases the flow to the left ventricle, and therefore the pressure in the left ventricle increases and pushes the septum back towards the right ventricle. So during respiration, we have a swinging motion of the interventricular septum, a seesaw motion as it is also called. So the hallmarks of tamponade are systemic venous return, which is shifted to systole during inspiration, impaired filling of the left ventricle during inspiration, and what we call interventricular interdependence, which means that one ventricle can only expand to the merit of the other. The physiology of tamponade is quite complex, and we can demonstrate many of the features that we discussed now in theoretical terms also with echo. But tamponade is still also a clinical diagnosis, so let's just shortly review what the typical findings are in the setting of tamponade. Patients can experience pain, tachycardia simply because they have to compensate for the low cardiac output, for the low stroke volume, dyspnea, edema, and eventually shock. But now that we understand the hemodynamics of tamponade, we can also explain clinical findings such as the pulsus paradoxus, where we have a decrease in blood pressure during inspiration. This is simply caused by the fact that we have interventricular dependence. Can the ECG be helpful? Well, yes, we can see low voltage or electrical alternance, in other words, variations in the amplitude of the QRS complexes. Sometimes we also see ST elevations, which could be a marker of associated pericarditis. But even when interpreting clinical findings, keep in mind that there can be various presentations, depending on how acute and how severe tamponade is. And also keep in mind that there is something called the low pressure tamponade form. In this form, we have relatively low intrapericardial pressures, but we also have a very low pressure in the left ventricle, often caused by hypotension or caused by volume depletion. Furthermore, patients might present differently if they only have regional tamponade, caused for example by a hematoma or localized pericardial effusion. I already mentioned the fact that the development of tamponade depends on how quickly the fluid accumulates. If it accumulates slowly, the pericardium can expand. Usually, if we have very large pericardial effusions, however, we do have at least some degree of hemodynamic significance. But there are also certain triggers for tamponade in chronic pericardial effusion. We already talked about low pressure tamponade in the case of hypovolemia. Other factors are tachycardia and intercurrent pericarditis. But now let us discuss what we see with echo. We have a collapse of the heart chambers, the right atrium, the left atrium, the right ventricle, and even the left ventricle. Here's an example of a patient who has inversion or collapse of the right atrial wall. This, however, is a sign we see even in small pericardial effusions, and patients often don't have any symptoms despite having an inversion of the right atrial wall. If you look closely, you will see that the left atrium also collapses. This is a sign of more significant hemodynamic significance of the pericardial effusion. Here we have an example of a subcostal view of a patient with a very large pericardial effusion. We can see that there is complete collapse of the right ventricle. In addition, the left ventricle is also very small and appears compressed. This patient certainly has symptoms. It is often very difficult to really assess the collapse of the heart chambers, simply because the heart often moves, especially in the setting of swinging heart, and it's difficult to say if you're really hitting the right ventricle in a view where you get the maximal extension. Always look at the inferior vena cava if you're assessing patients with pericardial effusion. In the setting of tamponade, you will find a dilated inferior vena cava which shows less or sometimes even no respiratory fluctuations. As already mentioned, the size of the pericardial effusion also plays a role. Here's an example of a very large pericardial effusion which shows a swinging heart motion. In this setting, you will very frequently have some form of hemodynamic significance. Of all the different echo signs in tamponade, I still believe that the abnormal interventricular motion, which reflects the interventricular dependence, is the strongest sign for tamponade. To demonstrate the dependency of this motion with respiration, you can actually use any view where you can see the interventricular septum. Here is the 4-chamber view. And here we also have the respiratory curve, which shows us exactly at what time the interventricular septum moves towards the left. If you look closely, you can see a snapping motion towards the left ventricle just at the moment when the patient inhales. This is a very strong indicative sign of tamponade. To demonstrate the interventricular dependence, you also use Doppler. Place the pulsed wave Doppler at the tips of the mitral valve leaflet and turn the speed with which the tracing runs as slow as possible so that you get many beats within the field of view. Then you will see that there are fluctuations in the inflow velocity, and you will also see that the smallest or the lowest velocity is found exactly at the time point when the patient inhales. This reflects the impaired filling to the left ventricle during inspiration caused by the hemodynamics that we discussed earlier. Normally, you will have no or only very little fluctuations across the mitral valve. In the setting of tamponade, those fluctuations will exceed 30%. You calculate the percentage of the lowest to the highest velocity. However, there are settings where it is difficult or even impossible to use the Doppler tracing. For example, in atrial fibrillation, where you normally have fluctuations of inflow velocity. It is also more difficult if you have a swinging heart motion because the heart moves in and out of the sample volume of the pulse Doppler, which can also lead to fluctuations. You can also use pulse wave Doppler in the hepatic veins, as you can see right here. The blood from the hepatic veins drain into the inferior vena cava and then into the right atrium. In the setting of tamponade, you will find an increase of the antegrade systolic component during inspiration. You can see very nicely here that we have an exaggerated flow during inspiration. Here is an example of a patient who has acute tamponade because of aortic rupture. In this short axis subcostal view, you can see hematoma within the pericardium and also free blood. This compresses the left ventricle, which is very small, and also the right ventricle. You can see this very nicely here in this 4-chamber view. There's only a very small cavity remaining of the right ventricle. The hematoma is here. Here are some images of the same patient. A subcostal view with the hematoma compressing the right atrium and the right ventricle. And here, the very large inferior vena cava. Now in this setting, it's very obvious that the patient has tamponade. You don't even need to perform Doppler, and the patient was highly symptomatic. He was in cardiogenic shock. In other patients, it might be much more difficult to make the diagnosis of tamponade, especially if you have hematoma following heart surgery. Here's such an example where you see a large hematoma located close proximity to the right atrium. In such a situation, echocardiography is difficult to interpret simply because it's very difficult to really delineate the hematoma and to assess the patient because they are often not easy to image. In such a situation, it is advisable to also perform other imaging modalities, as in this example, a CT. To summarize this chapter, here's a short checklist how you can go about if a patient is referred to your lab with the question of tamponade and he has pericardial effusion. Well, the first thing that is very important, always look at the patient. If he has symptoms of cardiogenic shock, well, then you've already made the diagnosis. Then take a look at all the echo features we discussed in this chapter, especially the septal shift and also the fluctuations in the Doppler inflow signal across the mitral valve. Remember that many patients have subclinical forms of tamponade. These patients have to be followed up.